Thanks everyone for coming. Kind of thought at the last session the room might empty, but I've see that it's not. I'd like to acknowledge the traditional owners of the land on which we're meeting and pay my respects to elders past, present and emerging. My topic today is to talk about Healthy Weight initiative that our primary health network is undertaking in the Hunter, New England and Central Coast region of New South Wales. We have the dubious honour of being the worst primary health network for obesity and overweight in Australia, only outdone, I think, by country South Australia and Western Queensland. It's fair to say that rural and regional primary health networks have significantly higher rates of obesity than metropolitan PHNs. It's also interesting to note that the COAG benchmark for healthy weight was set at 41.9. In other words, Australian society or Australian government is prepared to accept that around about 42% of us will be of a healthy weight and the rest will not. That's a bit of a scary statement for government to make. A new norm. My board thought that that was pretty appalling and we wanted to tackle something that is actually not part of our core funding. As we heard from Catherine King yesterday, primary health networks are not funded to undertake prevention, and the management of obesity does not attract Medicare MBS item numbers unless the patient has chronic disease. My board and I wanted to have a look at that, so we've started to embark on quite a novel approach to this. The objectives of our piece of work was to change the general practice or the GP's workforce workflow and to enable them to have the difficult conversations with their patients. One of the things that we did early in the piece was we actually consulted with a lot of our GPs, and a lot of them said that it was very difficult for them to have a conversation with their patients about their weight. They found it challenging and often confronting. So what we started to talk about are conversations that begin with statements like this: are you happy with your current weight? It's non-judgmental, it's a question. These sorts of strategies are actually empowering our practitioners to take clinical leadership in healthy weight strategies. We're also trying to reduce the risk factors for preventable progression of chronic disease by achieving a 5 to 10% reduction in body weight. We're looking to create sustainable behavioural change using general practitioners, their practice staff and the patients to encourage a whole practice approach. And we're trying to demonstrate the impact of a modest level of funding on the uptake of healthy weight in a general practice. So what our PHN is doing is we're actually undertaking a randomised clinical control trial and funding 26 general practices to undertake healthy weight intervention at the same rates as the lowest tier of healthcare homes funding. So in other words, GPs are being paid to undertake this piece of work. And it provides the opportunity to take up preventative health. The model features a 12-week structured program. It's an evidence-based program and it uses a tablet or PC-based platform called the Visual Fitness Planner, VFP. Just by the Visual Fitness Planner is actually a product that's used in about 90% of gyms across Australia. We've entered into a partnership with that parent company in America to change their tool and adapt it for general practice and primary care. So we're using a tool that's already in use but changing the way it's done. It's an interactive web-based platform. It uses data gathering and it embeds evidence-based educational weight management into the tiles, which I'll show you in a moment. The source of the IP, if you like, for this has been from our expert working group. We established an expert working group in the Hunter of lead academics and clinicians to enable us to put material into the platform that has a solid evidence base. The screenshot that you can see down on the right-hand side is one of the screenshots of the Visual Fitness Planner. It enables sharing of data. It captures data and it's transportable across multiple sites. It can be used in allied health practices. It can be used in general practice. It identifies the risk factors for chronic disease. Now, the screenshot there shows you a range of risk factors. This number here is the patient's actual age, and this is their calculated age based on the information that's captured out of the VFP. Feedback from clinicians is that this is very, very powerful when having a conversation with their patients. This is what the front screen of the VFP looks like. It's a 12-week. Each of those tiles can be clicked through, and just behind those are a variety of tools and information to help GPs, practice nurses, allied health providers have that conversation with their patient. What happens is, as a patient goes through the various sessions with their healthcare provider, they get emailed a link, and they then are able to review and follow through on the information at home and reinforce the information. This screen shows you two screenshots of the VFP. The top half of the screen has an avatar. The avatar is dynamic in the sense that if we move the parameters in the top left-hand corner around weight, we obviously don't change their height, not too often, but it does change. But if we change their weight, the visual aspects of the avatar change dramatically. The avatar can be rotated 360 degrees, and we found that that's a particularly engaging tool for patients, and patients are quite surprised at the representation of their body in this form. But the other interesting thing is when you actually change the weight by 5%, and the dramatic visual impact on the avatar then has an impact on their engagement with the tool. The bottom half of the screen here shows the more traditional risk factor calculators. The desired outcomes of our program was to address the increasing prevalence of obesity, aims to get a positive impact on chronic disease prevention, engage the GP community and allied health for the first time in weight management advice and support. It identifies measurable outcomes in a randomised control trial. We now have 26 practices who've enrolled in the trial, and each practice, we'll have a total of around about 1,200 patients. Each patient is given a Garmin device to be able to track their movement, and they attend the clinic on a regular basis to weigh in and have their metrics measured. Our strategy is not just about engaging primary care. We've also we're engaging in a community education program and a social movement. On the 21st of November this year, we will be having a pitch night on the Central Coast in New South Wales, where community organisations will be able to bid for funding to undertake a social movement activity with a view to getting their community moving, getting their community engaged in physical activity and healthy food choices. We've run a couple of these over the last year, and they're very interesting and very powerful ways of getting communities involved. We want to support the community to be engaged with this and to work with their local providers. As I said, it's a 12-month duration randomised controlled trial. We've got 26 practices who will recruit a maximum of 48 patients. At the time of producing this slide, we had 20 practices who'd signed up, 10 in the high intensity, which is the full intervention group, 10 in the low intensity. The low intensity or control group get access to sessions 1, 12, then they check in at 6 months and then again at 12 months. So they're sort of your typical presentation and management. The high intensity get the 12-week program, a check-in at 6 months and then again at 12 months, but they're also able to come back to the practice on a regular as-need basis. We intend to undertake a process evaluation to look at compliance with the intervention, but also using the quadruple aim to look at the experience for both participants, for the patients, but also for clinicians, and try to identify the barriers and the enablers for this. What we're very aware of is that there is very little evidence that programs beyond 12 weeks have a sustained and lasting effect. We want to see whether or not engaging with general practice and primary care can actually change that, and whether the effect is lasting. One of the things that we did do as a primary health network was we decided to establish an obesity strategy for our footprint. The purpose of this was to essentially solidify our thinking around what are the elements of managing overweight and obesity at a community level. The first one is continuing professional development. So encourage and provide education and upskilling for healthcare workers to work with their patients to make healthier choices. The second one is to look at models of care, ensuring that high quality data is collected, and we developed some innovative models of tackling obesity and overweight. The third one is to provide some research, albeit a fairly light touch version of the research, into what works in this space, because there's not a lot of evidence in the world around this, particularly in the primary care setting. And the third one is to look at the use of social movement. Social movement, and I have to be really clear here, this is not social media. This is social movement. So if you want to think about social movement, think about the Clean Up Australia type activities where communities get behind it. We've got communities who want to get involved at it, both at a local government level but also at organisational level. And we believe that our role as a primary health network is to enable that, to make the tools and the resources available to have that happen. Thank you. I'm happy to answer questions. Thanks for listening. Yep.
Overweight and this kind of health at every size, and that the end point is not somebody's weight, but the end point is prevention of chronic disease, and that we seem to still be focusing on a visual thing, a body image thing about the size of a person, not necessarily the outcomes we really want to focus on.
Look, that's a really good point, and the consumers in our expert reference group absolutely pushed that and pushed it hard. This presentation is very much for a group where this sort of language is appropriate. The VFP has, we've passed that through a couple of filters. One is around the avoidance of what I will call fat-shaming language, and the second one is around health literacy at its fundamental level. Very often, and one of the things that we found when we did our 26 community consultations is, I remember a lady in Cessnock. Those of you who know Cessnock, it's quite a underprivileged area of the Hunter Valley, but remember a lady in Cessnock who said to me, John, I just don't know what to believe. You know, I can't get to what is the right thing to do. You know, is it paleo? Is it Jenny Craig? Is it this? Is it the other? So one of the things that we wanted to do was to take all of that out of the picture and say to people, this is what the evidence says. This is where the evidence is, and then translate that into simple language. One of the one of the finalists for our social movement pitch night on the 21st November actually has a whole program around healthy choices, but it's in a way that is very community level accepted, and I'm going to go out on a limb and reckon it's going to win, but you know, we'll see on the 21st, because it's a really sharp program.